Hi, this is a 3 or 4 minute video that will show you how to set up the V60 NIV ventilator that we have in Addenbrookes Emergency Department. Before I get into it though, I have to say, this video is intended for doctors and nurses who are already competent in managing patients with respiratory failure and only need a reminder in how to set up this device. Let's take a look at the hardware first. On button here, battery indicator light here. The battery does last several hours, but you are going to need it for transfer to the ward, so please keep the device plugged in when it's in use. Power cabling. Oxygen tubing goes in the main ports in the wall. There's an oxygen cylinder on the base for transfer. Patient circuit attaches here and pressure monitor tubing attaches here. It's a touchscreen device, but there's a dial pad as a backup just in case you can't use the touchscreen. There's a specialized circuit that comes for the device that's not compatible with any of the other ventilators. It comes with an HME filter in the packaging. Goes on here, and your pressure sensor tubing goes on here. There is also a T-piece packaged separately that can fit on here, and that will allow you to attach a nebulizer chamber so you can keep giving nebulizers to your patient. Finally, starting it up. The V60's got several modes and lots of options. I'll show you one way to safely provide NIV to a typical patient with type 2 respiratory failure. When you turn it on, it'll start working straight away with the settings it was running last. You can press standby to temporarily stop it. It takes a couple of cycles just to quieten down. Then select modes for BIPAP. We want ST, that's spontaneous timed. If it's already in ST setting, it'll have batch written above it. And now, here's your settings screen. Set your IPAP initially to 15. Accept it. Your EPAP initially to 5, and accept it. The rate, of course, is just a backup rate. The machine will deliver breath anytime the patient triggers it. This is just in case of a period of apnea. The I time, a safe start is 1 second. That's the duration of the inspiratory pressure delivery. And rise sets how rapidly the machine goes from expiratory pressure to inspiratory pressure. And as you increase the number, the rise is more slow. It does reduce the tidal volume a little bit, but a slow rise is more comfortable for a patient who's having difficulty syncing with the machine. But I'd recommend you start it at somewhere middle of the road, like 2. Ramp we tend not to use in the emergency department. I wouldn't bother with it. Oxygen, set your FiO2, accept it, and then press activate. And now the machine's ready to deliver it. If you connect the circuit to the patient at that point, it will detect flow and it will start triggering breaths. Alternatively, you can just press restart. Okay, next steps. Once you've got the patient up and running on NIV, you need to gradually increase the inspiratory pressures over the next half an hour or so to get the patient somewhere between 20 and 30 centimeters of water. You need the patient on continuous monitoring while they're in resus. Do check the Trust's respiratory failure policy, because obviously there's an awful lot more to the management of a patient in respiratory failure than what I've discussed here. And that's it really. Okay, all the best.